Okay, welcome everyone. I'm Madeline Bell. I'm the president and CEO at Children's Hospital of Philadelphia, and I'm your moderator today. And I'm joined by two of my colleagues who are going to introduce themselves. We'll start with Jack Lynch.
Thanks, Madeline. My name is Jack Lynch. I'm the president and CEO of Mainline Health. We have 5 hospitals in the Mainline area just outside of Philadelphia and headquartered in Bryn Mawr, Pennsylvania.
And Bruce?
Bruce Meyer. I'm an obstetrician gynecologist by training, and I currently manage Jefferson Health, which is a 14-hospital system in the Philadelphia region, headquartered in Center City, Philadelphia.
Okay, well, it's really great to have everybody joining us today. As you can imagine, our industry of healthcare has been really impacted by the pandemic. But today we're going to be talking about some of the opportunities that has created for all of us as healthcare providers. And so I'll start with a question for Bruce. I want to know, how Jefferson has really taken advantage of this crisis to innovate during this really challenging time.
Sure. There's not much in the way of silver lining when it comes to COVID, but pre-COVID, we were doing relatively small amount of virtual visits in telemedicine, about 200 a day, give or take. At the peak of COVID, we translated pretty heavily into an online structure, and we're doing as many as 3,500 visits per day and have kind of steadied out at about 2,000. It's also really enhanced our hospital at home structure. We've been able to leverage that to take care of now close to 1,000 COVID positive patients on oxygen at home and save them a hospital stay. So that's been pretty profound. And I think the third thing I would mention is for us, as a relatively new health system, combination of lots of prior health systems, it has allowed us to really come together and function as a true system, where we were able to move respiratory therapists, critical care physicians, ventilators, PPE to the site where it was most needed, where we were seeing volume changes, rather than kind of being isolated entities that were working on our own.
Madeline, I just add a couple things. I think Bruce's comment about systemness has really been true for us as well. We were a pretty tight system, but any sort of silo activity sort of got taken out by all of this. The other thing I would say that's different is that the southeastern Pennsylvania hospitals and health systems, I think, have communicated more since March than we did 2 years prior. I think we've had collaboration from all of them. We've shared testing capacity. There may be even have been some PPE exchanging. There may have been some patient exchanging. I just think we all got very, very focused on keeping our employees safe and being available and ready to care for the community, regardless of how many patients ended up hitting our hospitals.
Yeah, I'm really glad you mentioned that, Jack, because maybe not that many people knew that we sort of took away any competitive barriers and really talked to each other and coordinated and collaborated and shared ideas and best practices. Which I definitely think brought a new level of collaboration. So I'm glad you mentioned that. And Bruce, you talked about telemedicine, and the numbers are staggering. All of us have gone from maybe tens or hundreds to thousands of visits pretty much overnight. I'd love to hear from both of you about what you're doing to sort of build your internal infrastructure to make that sustainable, and how your patients feel about, your patients and your providers feel about the telemedicine experience and where that might be going in the future. So maybe Bruce, you can start there.
Sure. Well, we were fortunate to have a relatively well-built infrastructure that was not that we were, using. We took a lot of pride in doing 200 visits a day. We thought we were really advanced, candidly. But we had a lot of struggles with our providers in terms of their willingness and their acceptance of virtual visit kinds of structures. We just had a lot of folks who felt like that they couldn't take as good care of patients. When a pandemic hits and people can't get to you, suddenly providers find a way And what it has really done is convert the skeptics into believers. And that's been enormously valuable to us. So that to the point now where we're even structuring sort of the day of our primary care doctors and of our specialty-based doctors so that we know we always have someone who's doing a virtual visit or can add a virtual visit to their calendar and those kinds of things. We really think that 20 to 25% of our ambulatory care has probably permanently switched to a virtual environment and is really not going to go back. The public, I would say, acceptance of the virtual visit was fantastic in April and May because it was like the only way I could see a doctor and feel comfortable doing it. What we have found, interestingly, is that as we have opened up more and people have gotten more comfort around mask wearing and social distancing and those kinds of things, that older patients have started to come back to the office and are a little less comfortable in the virtual environment, and younger patients really want to avoid the office because they love the convenience of the virtual visit. And I think we're going to have to sort of explore that and see how that evolves over time.
Yeah, the only thing I would add, Madeline, is I think we're all being challenged by the virtual visits from a reimbursement standpoint. And while the reimbursement was temporarily given an equivalent payment for an office visit, I'm told by the practitioners that they actually are consuming the same amount of time and effort in seeing a virtual visit as they would a in-office visit, and that the MA is involved in getting things ready. And so I'm not convinced that the cost is going to be that much lower for us in doing virtual visits. But I was told the other day it's 60 cents on a dollar in comparison to an in-person visit. Clearly, we've got to come up with a way that where a virtual visit is adequate for the patient, that we have that available and it's easy, but that we're reimbursed in a way that doesn't cause us to be disincentivized to provide that level of convenience and comfort for our patients.
Yeah, I think that's a great point, and I'm glad you brought up the generational differences, Bruce, because as a children's hospital, I could tell you that our patients and their parents are digital natives, and they want to be able to relate to us digitally in a different way. So that's a window into what your patients and families are going to be like in the future. And so I think we're all obligated to try to figure out a way to make this work. And as Jack, to your point, influence the payment model to ensure, the future sustainability of it. And certainly as, families are homeschooling children and providers are homeschooling children as just examples and doing what they can to socially distance, it's a really good way to continue to keep connected. So Jack, I'm going to switch gears just a little bit. I think one of the things that has happened for all of us is that there have been anxiety among people the general public about coming to hospitals. I mean, we've all seen on social media, doctors and nurses in tears and tents outside of hospitals and lots of drama. More drama than is playing out on television. Sometimes we saw, on social media and in the media as well, at hospitals. And so I think that a lot of patients and families are fearful of hospitals now. And Jack, how are you guys overcoming that? How are you educating the public about hospitals and the safety of hospitals during this pandemic?
So Madeline, you described something I think that we all have been going through, and that is when we threw the switch to off, and as Bruce reminds me, we really never shut off, but we removed all the elective activity, if you will. But to ramp back up, it's been much more difficult. But even for those of us that have been able to ramp back up and have capacity for a lot more care than we're currently providing, it gets back to this concern on the part of the patients. I think early on when we started to ramp back up, there was a lot of hesitancy, a lot of concern over coming to the hospital. I think we, as well as others, have done a lot of work with regard to screening, universal masking, hand washing, social distancing. But to me, the single biggest thing that makes the difference is when the patients and family members bring their loved ones to the hospital for a hospital visit or for a outpatient visit. They're watching carefully. Are we doing all the things that we're saying we're doing? And so I think it really becomes paramount for all of us to be the model for our communities. I tell people all the time, I'm more comfortable in my hospital or one of your hospitals than I am in other public places, because every one of our employees understands the risk they're at and the risks that they're putting others at. We've had a number of people convert to positive in our workforce. We've not been able to identify a patient that's been exposed by us and left our hospital positive as a result of their encounter with us. So I think that that's part of it. It's the training, it's the screening. We launched a campaign with the American Heart Association about don't die in doubt. And I know you and our other colleagues have heard stories from EMS about patients they've found in the community who probably had put off coming to the hospital and were pronounced dead at the scene. And I think there's a lot of speculation that a lot of people were in fear of coming to the hospital when they had chest pain or when they felt a little dizzy or when they had a little left-sided droop, and when in fact those are the patients that should have been in the emergency room. And I think it's our responsibility to the community to indicate we are a safe place to come back to. We're a safe place to come to for elective procedures, and we're certainly a safe place where you must come if you've got a need for emergency services.
Yeah, I would just piggyback and say we've had the same experience, and now we're over 50,000 non-COVID patients cared for in our hospitals since the onset of the pandemic. And we can't identify any transmission of COVID in that situation. And so I think I feel the same way that Jack does. The safest place we have is probably our hospital. Everybody's in a mask. Everybody's wearing PPE. Everybody is washing their hands. Everybody is socially distancing to the extent appropriate. And everybody is very deeply aware of the threat. I understand why the anxiety very, very high in the March, April, May timeframe. But now we have a track record that proves that we know how to keep our staff safe. We know how to keep our patients safe. And we have to prove it every day, because Jack is absolutely right. The shift in what I receive in terms of patient comments and complaints, which used to be candidly about things like food or
Parking.
Are now all about, well, the guard at the desk had his mask and it didn't cover his nose, kind of thing. And so we have, and great, we want to hear about that. We want to, make sure we are doing safe protocols for people. But I think it's the experience of care and people's ability to tell their loved ones and friends that, wow, this was very safe. Or when I came to ambulatory, they let me wait in my car, and then they texted me. And when I came in, I didn't wait in a waiting room. I came right into an exam room. I talked to my care provider, and then I went right out back to my car. They did everything they could to keep me safe. I think that's the stuff. We can do all the commercials we want, and at the end of the day, it is the experience of care that is going to create the trust between the public and the care providers.
Madeline, I'm sure both of you have seen this, but we've got units where we took care of hundreds of COVID positive patients on respirators, very, very sick, where not one employee got a positive COVID test result. Where we've had our employee exposures tend to be around a very small nursing unit where it was too tight quarters and people weren't wearing their PPE, as they needed to outside of the patient room. They need to wear it outside the patient room, or in a break room where we all mysteriously think, oh, it's time to eat food so we can take our mask off and we're not going to put ourselves or others at risk. So I really impress upon people, if we follow the rules, if we mask, if we wash hands, if we socially distance, the caregivers that are caring for active COVID positive patients at the sickest moments are being protected because they're being smart and they're adhering to the guidelines.
Yeah, I think we all understand that, and how we communicate that to the public, maybe in tangible ways, or in ways that are a little more overt. I mean, we clean at night. We do a lot of our deep cleaning at night, and we're starting to pivot to doing that during the day. We used to not do it in a waiting area because we didn't want to disturb people, but now, we're going to do that during the day just because that visible reassurance is so important. So I think you're right about, all the commercials in the world, you really just have to come into a healthcare environment and see. But I think we all three of us agree that the safest place to be is in our hospitals.
Madeline, think about all the industries that are hopefully watching us and listening to us. And what I would tell all of them is go back and watch your staff. Go back and watch your workforce. I watch a PICO crew or any other crew out there in the environments that we can see, and they're just not adhering. And I shouldn't pick on PICO, but they're not adhering to the protection that we're all being told we need to. And the challenges in the schools. If the kids in the schools do what they're told, we will likely not see outbreaks in those areas.
Yeah, especially colleges, right?
Yeah, I have a college student, and I would say, and you look at the data out of the colleges, nobody's getting infected in a classroom where they are 6 feet distance and wearing masks. Nobody's really getting infected as they're walking to and from class. They're all getting infected at a party on Tuesday night or Saturday night where people get sloppy about how they wear their mask or distance appropriately. And those are kids with not a fully developed frontal lobe yet. And, okay, so there's maybe some legitimacy in terms of their excuse. But as adults, it is true just walking around Center City or walking around in my neighborhood, folks are really good in the grocery store. And then they take their mask off right as they exit the grocery store to get to their car. And then they walk right by you. It's those kinds of things. If people were as rigorous as our staff is in our ambulatory and inpatient environments, we would suppress the disease to the point where, we would have very few cases and we would contact trace them and isolate them, and we could keep the disease deeply suppressed. Where we struggle right now is because human nature is just that we get sloppy.
Well, and we're getting mixed signals.
Yeah.
We're not going down that path. We need to stay focused on, what science has told us and what we should be doing. And again, I credit the leaders in the state of Pennsylvania as well as the city of Philadelphia and the surrounding counties. They've been really good about adhering to the guidelines that are coming out of both the CDC and the Department of Health. And, Dr. Farley and his colleagues in the counties, I think, have given good advice to those communities. And we've, not seen the outbreaks in the second surge like some of the other states and cities have.
Yeah, I think that's a really great point. We're lucky that we have the appointed and elected officials, that we have, and we've also all been communicating and partnering with them well, which has been another silver lining in this. And I think the points that you're both making is that we've learned an incredible amount in the last 6 months about this virus. And we now know how to really protect ourselves and to protect our patients and their families. And so, we just have to keep that drumbeat up with the community.
Madeline, this might be a good time. Maybe Bruce is in a better position, or you as a nurse than I am, but reinforcing the importance of people getting the flu vaccine. Let's not talk about the COVID vaccine, but the flu vaccine. Despite the fact that people aren't all in the workplace like they normally are, despite that there's all kinds of people walking around, thankfully, with masks on and hopefully washing their hands, we all need to get the flu vaccine.
Yeah, I think all of us are doing that in the healthcare environment, but it couldn't be easier to get a flu vaccine at the grocery store or at the drugstore this year. There's signs everywhere. It's free, and it's really important. And Bruce, I don't know if you have any other.
Yeah, if there's ever a year in which somebody who was sitting on the fence about whether or not to get it, or, this is the year to get it, because I don't think any of our clinicians want to see anybody with a combination of the flu and COVID. We're just not sure that's a survivable problem. And we don't want to create additional vulnerabilities in our community. So this is the year to get a flu shot. Madeline, you're absolutely correct. It is easily available. It is and ubiquitous right now. And I would strongly encourage anybody who's on, I've gotten my flu shot. Our staff are getting their flu shots. We're trying to encourage everybody. This is the year to get a flu shot.
And that sort of points to, well, why do I need to get a flu shot? If I get sick, I'll go to the hospital. We cannot bombard the hospitals with flu and a potential surge in COVID. And, God bless our friends in New York City, those that were in healthcare. They did an amazing job in unbelievable circumstances, but there were only so many resources. And I can't imagine what it would be like if we had that kind of surge of COVID coupled with a surge of flu at the same time.
Yeah, really good point, Jack, to not overwhelm the hospitals this winter. So let's pivot a little. We talked about the impact of COVID on the general public and their attitudes towards healthcare. How have you both been supporting your staff? What toll has this pandemic taken on your staff? We're now 6 months in, and they've been enduring this. And all three of us, I'm sure, because I know we have COVID positive patients in our hospital still. How are you, what are you hearing? What are you seeing with the staff? How are you helping them manage and cope through this?
So Madeline, we've been talking about the mental health aspects of the impact of post-traumatic stress syndrome on our staff almost since the early deaths. Mainline Health is up to almost 500 people that have come into our hospital, been admitted, and have died from COVID. So that means that there were nurses that used to work on an orthopedic unit that may have never seen a death or not seen one since nursing school, who were seeing multiple deaths in one shift. And that just takes a toll on people. I think I got thrown a glass of hot water as opposed to cold water in my face when we read the story about the doctor in New York who committed suicide. And that's where it dawned on me that there, by the grace of God, it could be any one of our environments where something that tragic could happen. So we've spent a lot of time focused on laying out what resources we have available with our mental health professionals, with our employee assistance program, with our critical incident response team, with our pastoral care program and chaplains, as well as each other. And, we use our safety tools, have each other's back, keep an eye, pay attention to detail. If I see you stressed out, if I see you overwhelmed, I need to alert somebody. It's no longer when, clinicians can think I can do everything, because we can't expect them to be able to do everything. We had a mental health crisis before this pandemic started. We're going to have a bigger one after this is over. The healthcare workforce is only one segment of that crisis, but I think particularly with the healthcare workforce, we've got people, nursing homes have people that have seen more death in 4 months than they would have ever expected to see in their careers.
Yeah, our experience very similar. We trained over 400 nurses who were non-critical care to become critical care nurses in literally a 30-day period. Those nurses not used to seeing morbidity and mortality like we saw. And to Jack's note, we've seen over 700 deaths at Jefferson, and we were looking at death rates that were 4 times our normal mortality rates. So even our experienced ICU nurses were seeing things where 6 or 7 people a day would die, where in a routinely you would never see more than 1, and infrequently 1 kind of thing. So the truth is that because the pandemic has required so much diligence on the part of our staff, we're still worried that a large part of our staff hasn't had the time to process that. Now, we've done a lot of things in terms of behavioral health supports, virtual groups. We've done stuff before and after shifts around mental health. We've created a tap out program where you can tap yourself out, or one of your colleagues can say, you know what, I can see your stress level is overwhelming. I'm going to tap you out and let you step away, kind of thing. But I think we're genuinely worried that there is a PTSD aspect to this that we have not yet seen at all, to a degree. And we are, I think, starting to see the tip of the iceberg of older nursing staff who are deciding that, you know what, I can change my career now. The big wave is over, and I just can't face another big wave. And so I'd rather retire. I'd rather move to some other nursing environment, and I'm just not able to manage in that environment. We've seen a few of those. I think we're worried that over the course of the next year or 18 months, we're going to see significantly more of that as people begin to process and have to deal with the mortality and morbidity that they witnessed.
Bruce, I love your tap out. We did not use something like that, but I love that concept. We did something pretty cool. Barbara Wadsworth, our chief nurse executive, was starting to see that burnout of staff not used to caring for the dying. And so we ended up creating end-of-life support teams, and those end-of-life support teams would be deployed to patients that were in the end-of-life period. The other thing I don't think the general public understands, and again, all of us in healthcare understand this, our staff became the family members for these patients. And I didn't know about that until I listened to something on KYW. One of our nurses called in when they were doing a program to thank people, and she said, I want to thank the family members of the patients I have the privilege to care for allowing me to be their surrogate family members. I was like, wow, we're asking these staff members to be caregivers. And at the same time, we're asking them to be the family member in the absence of that visitor and connecting with the family in a different way than they ever have before. So I think that, we've seen the trauma on the staff differently than their routine trauma, because now they're literally the surrogate for the family members that can't be there.
Well, I also think that although it seems trivial, I walk to work and seeing the sidewalk chalk, and even this morning I saw a flag hanging outside of somebody's house that said, "Thank you, healthcare heroes." And, with all the other people I walk with to work, lots of doctors and nurses, they always turn to me and say, like, how nice is that to see that, just thank you, and sidewalk chalk. So I think there's a lot that the general community can do to, don't give up that supporting your healthcare workers, that moral support, that cheering on, that thanking people has been really important. And, we're 6 months in and this is not even half over. So, just keep that support going. I think that's important.
Well, Madeline, I know that the staff's response to the first responders, police, fire, and EMS at all our facilities was just overwhelming for them. Tears. Yeah. And I hope those people, first responders, police officers, and firefighters, feel their support going in the other direction. It's difficult for us to all circle around a police department or circle around a firehouse, but I know that the healthcare workers are as supportive of their colleagues out on the street as their colleagues on the street have been to them.
And I would just mention, it's not just frontline sort of nursing staff and those kind of things. The people who clean the rooms, the people who bring the food, the people who bring the supplies, they're taking the same level of risk. And we don't think about them very often, but they're no less heroic than the folks who are in a room with the patient.
I'm so glad you said that, Bruce. Absolutely. In fact, they're definitely the unsung heroes in all of this, for sure. So I think we only have about 2 minutes left before we open it up to the audience questions. We started talking about innovation and how we all innovate during really challenging and ever-changing times. Would love for you to say, like, what does innovation mean to you during these times? Just sort of off the top of your head, Bruce.
Yeah, I think innovation is a tough word to describe. So what I would say is more transformation. I think that this crisis has been truly transformational in the way that we think of how we care for patients. We talked previously about telemedicine and virtual visits. I think it's transformational in the way that we recognize our staff and what they are doing every day. We just talked about healthcare heroes. And I think it's transformational in our relationship with our community and families and patients that we care for. We, in an odd way, we are now being held accountable in a different way than we used to be. We mentioned sort of how people look at us as heroes, but they also then say, what is your cleaning protocol? And are you wearing your mask appropriately? And are you socially distancing? And those kinds of things. That level of accountability and trust is, we're reestablishing it. And I think all those things are transformational for our relationship and the way we provide care.
Yeah, Madeline, I would pick up on the transformational and say, we've almost just had to get out of the way of our clinicians, our ID practitioners, our critical care folks. Things that it used to take us a long time to move through the bureaucracy of approval, we've shortened that time frame. And I think the focus is, what do we need to do to save this patient? What do we need to do to care for this patient? What do we need to do to protect our employees? What do we need to do to protect our medical staff? And things that used to take us a lot longer to do, we realized we didn't have the time. Dennis Pullen quoted, and he may have picked it up from somebody else, the CEO at Virtua. I heard him say the other day, CEOs are usually focused on 5 years, 3 years, and maybe a year, in the time horizon. We went into focusing on what are we doing in the next hour. And, we had a new executive join us from outside of healthcare. And he said to me one day, Jack, I'm just blown away by the firefighting approach and the level of detail that the executives are involved in. I said to him, I think that's because of the time we're in. People are throwing themselves all in to help solve the problems much quicker than they would have been solved in the past, because how quickly the information is changing with regard to the virus, and how important it is to protect our staff and to do all we can to help our patients.
Yeah, I'll give a great example of that in that we were able to leverage our daily system huddle into changing standards of care for care of COVID patients literally in a day. And we used to complain bitterly that it would take us like a year of debate to change one care protocol or one set of orders or those kinds of things. And now we did it like in an hour and then transmitted it in the next hour to the entirety of the organization. So what I've said to the team is like, okay, no more excuses. Doesn't matter whether it's COVID related or not. If we need to do something, we've proven we can do it in a day. Let's just keep doing it in a day.
Yeah, that's that quick decision making that guided us all through the beginning of this pandemic. Hopefully that will sustain. So we have some great questions that have been teeing up, and I'm going to start reading them off from the audience. Somebody's asking, what are hospitals doing to support families who are inpatient and who cannot have visitors as advocates, while they're in the hospitals?
So we maintained even throughout COVID the ability of folks to visit their loved ones at the beginning and end of life. So at birth, we always allowed one visitor, and we trained them on PPE, and we gave them a full PPE set, et cetera. And at the end of life, we always allowed one family member as well. As volumes declined, I would say probably as of sort of 1st of June, maybe the last week of May, we relaxed our visitation pieces so that you could have one visitor at a time. Again, appropriately in masks and social distance and those kinds of things as they entered and exited the hospitals. We have really tried very hard to maintain the connection between families. Jack mentioned, and I think this is very profound for our staff as well, I think our staff spent as much time doing direct care as they did using a cell phone on FaceTime or some other mechanism, allowing patients to talk to their family members. One of the things I think that's challenging for us that we're trying to figure out is how do we create that functionality for patients all the time? And so we have really tried to transform. One of the interesting things we've done is to go through every single building at every single site and make sure we have enough repeaters so that the wireless functionality is at its highest level in patient care areas. So there's enough bandwidth so that people can actually talk to family. Because it's hard. It's tough enough to be terrified that you're going to die from a disease and not really know, and have either limited visitors or no visitors during that time period.
So we've done some similar things, Madeline. We've done the end of life and the beginning of life stuff all along from the beginning. I'm very rabid about this. And the reason I'm so concerned is all you need is one person that comes in with COVID that exposes an intensive care unit full of people who aren't thinking about the fact that that person who's asymptomatic and doesn't know they're positive. And all of a sudden, I got to shut down the unit because people have been exposed. Now, again, if they're all wearing masks, theoretically, it shouldn't be a problem. But our psych unit right now is closed. We had 6 employees convert and several patients, and it was all because of one patient that came in positive. And when you introduce a visitor times the number of patients that we all have in the hospital, the screening requirements for those visitors are huge. And then you've got more people walking around. We have no volunteers. And anytime we have the students, we just brought the students back in at the end of August, beginning of September. We've already had to take one school out of the student cycle because they've had an outbreak on their campus. So as difficult of a decision it is, I think it's incumbent upon us to find alternative ways for patients and families outside of the birth and outside of the dying process to connect with their family members so as to reduce the risk that they're going to get exposed or the employees and or medical staff are going to get exposed. One cool thing we did at Bryn Mawr Rehab, where they have lengths of stay that are much greater, every Saturday and Sunday, I think they have in the outpatient area, they have phones, and on the other side of the window is another phone. And so patients can come block a 15-minute session on one side of the window and their family members on the other, and it feels really cold. But on the other hand, if I have a visitor come in unknowingly and expose that patient to COVID and that patient gets sick, it just goes on. So as tough as the discussion is, I think we're going to still continue to be pretty rigid about and we've actually had a patient leave us and go to another hospital because they have less stringent visiting. And I hate to see that happen, but I've got to protect our staff.
Yeah, I think for all three of us, safety is our number one priority.
Yep.
For our staff and for our patients. We can't compromise that. We're trying to do the best that we can to accommodate the need, the real psychological needs of patients and families. But safety has to remain our number one priority.
Yeah, I agree that we're trying to reduce events of harm, but at the same time supporting people. But we have to err towards ensuring that harm is not done. So there's a great question about health equity, as the three of us know the world of health equity and how the pandemic has really put a spotlight on the fact that not everyone has access to equitable care, in particular those who may not have internet access or perhaps may not have a phone that provides the right data service in order to have a telehealth visit. So how are you ensuring that these patients who may not have that access have access to care?
So, the digital divide is a tremendous conundrum. So we are trying to work with community agencies and have been providing some enhanced data plans for folks who have a phone that is enabled, because what we have found is that the issue is less that you don't have a device and more that you don't have a data plan that allows your device to do the kind of work on telemedicine. We're trying to work with Verizon and other providers to see if we can cross the digital divide in a more thorough way. That's really tough. We're not at a place where I think we're able to provide devices for people per se. But I think getting the digital divide crossed is more of an entire community and societal problem than it is an individual health organization's problem or even a collective of health organizations' problem. As Jack mentioned, I think this crisis has brought all of the health providers in our community together in a way that really we weren't able to do previously. And all of us, I think, face that same dilemma. So we've got to work with the community and work candidly with our elected officials to try to figure out how do we provide better internet access and how do we provide the enabling of devices to be able to access the internet. It's one thing to have a smartphone, but if your data plan won't let you do anything, with FaceTime as an example, then it's tough to do a virtual visit.
Madeline, I would add that, throughout this entire pandemic, we had doctors' offices that remained open. We had emergency rooms that remained open. We had urgent care centers that remained open. So even for those who couldn't access it through telehealth when it would have been appropriate, they still had the ability to access the same kinds of services that they would have had. Even if it was, it might not be elective because we weren't doing a lot of elective things, but if they needed to see a doctor, there was a way to see a doctor. One of the things I'm very proud to be a part of is the 13 CEOs of health systems in the region that over a 24-hour period of time adopted 8 steps that we all believed would help eliminate racism, which we talked about being a healthcare crisis. And it literally, we picked up on some language that came out of Chicago and we circulated it to all 13 CEOs in the region that head up all of the systems of southeastern Pennsylvania. And as I said, within 24 hours. And there are things bulleted in those 8 items that talk about access to care. And I think what we all have collectively committed to is to work in our silos as well as working with each other and other organizations that are invested in these same kinds of initiatives and figure out how do we eliminate racism and other forms of discrimination in the delivery of healthcare, which result in disparities of care. And I'd like to believe a year from now, we're going to be one hell of a lot further along than we are today.
I do think that, to Jack's point, we started a couple of years ago, but really intensified it during COVID in terms of looking at healthcare outcomes by race and ethnicity, as well as gender and gender diversity. And I think just shining that spotlight on what exactly our data shows heightens sensitivity and makes people aware that there are true disparities that we have to overcome. I think so that's I think a very critical piece for us. And then I think the other piece is we have to solve the distrust in parts of our community that has been built up over decades because the healthcare system either ignored them or took advantage of them. Our African American community, and this is not necessarily Philadelphia, this is really a national problem, has been experimented on by healthcare. And our African American community has a very long memory of that experimentation. And we've got to prove that we are non-racists, that we are not experimenting on people, and that we can in fact provide equal access to care and equal outcomes of care for all communities in the southeastern Pennsylvania and southern New Jersey area.
And I think all of us in southeastern Pennsylvania are diving deep into just the COVID virus and trying to understand why are there the disparities of death? Why are there the disparities of contracting the disease? Why is there disparity in the hospitalizations? And actively saying, not just acknowledging that it's occurring, but what can we do to level out all of those things so that there isn't a disproportional outcome or a disproportional outbreak?
I'm glad to see both of you so passionate about that topic. I think we're almost at time. Maybe we'll end by asking you each to say what changes brought on by COVID do you think are here to stay? So Jack, do you want to start?
Yeah, from a non-clinical, we've talked a lot about the clinical things. Mainline Health was very resistant to allow remote work from home. In fact, I was losing employees maybe to the two of you.
No.
we weren't really comfortable with this concept of working from home. And I think part of that's because most of my workforce can't work from home. It's very difficult to let a nurse at the bedside work from home. And so we resisted it. And I would say we probably have 1,500 people working from home. They're extremely productive. They've been very good about it. And I think that's here to stay. And what I think we're going to have to try and figure out, and I don't know the magic to this yet, but we all, three of us and our colleagues, have very tight cultures within our organizations. And I think a lot of that revolves around the day-to-day interactions with our colleagues in the workforce. I worry about an entire IT department or an entire finance department or an entire accounting department working from home and not having that culture. So I think we'll end up having permanent work from home, but I think we'll rotate people where they're at least spending some portion of each month in an office with colleagues so that that culture is maintained and in fact enhanced.
Bruce, do you have any thoughts before we wrap
up?
Yeah,
I would certainly echo Jack's thoughts. We have 7,000 people working from home where previously we had about 400. We've now learned that we can do it and we can be good at it. I think for that same reasons Jack's describing, I think we expect that it'll be 80% work at home and 20% work in person because we need to help create that culture and that mutual accountability kind of thing. I think the other thing that I would say is a very permanent change. We talked about the virtual visit structure. One of the big transformational things that we've seen is our ED visits are down by about 20%. And the ED visits that appear to have disappeared are the things we used to think of as urgent care kind of stuff. And they appear to have moved mostly online or into our urgent care structure. That's probably a good thing in the long run. It was a lot of stuff in the emergency room that probably didn't need to come to an actual emergency room and spent a lot of money to be there. But we think that the way the public views the emergency room is likely permanently changed in terms of what they want to come to the ED for.
But don't die in doubt.
Yes.
Don't die in doubt. I think, Jack, to your point, one of the most profound statistics that I have seen from a Jefferson perspective is that during the height of the pandemic, we saw emergency room visits were down by 20 to 30% for heart attacks and for strokes. And at the same time, the dead on arrival calls to 911 were up threefold. So people were clearly staying at home when they probably shouldn't have stayed at home. That's a dangerous thing. What I would say, though, I think it is a permanent change that we think is profound for our organization, is that our focus on emergency preparedness and disaster planning is candidly vastly different now. Where we used to think of it as that's an annual exercise that we should do because at some level the Joint Commission likes it when we do so, and it's probably a good thing. Now we think of it as that's a vital exercise that allows us to do something that might in fact save a ton of lives and certainly will save resource and stress for our organization. So that kind of disaster preparedness, emergency preparedness, a renewed focus and maybe a much more important focus for our organization.
Well, not a reliance on a national stockpile.
Not a reliance on a national stockpile.
Well,
yes.
we're out of time. Thank you. The time went very quickly. Thank you so much, Jack and Bruce, and thank the audience for tuning in with us.
And Madeline, thank you to you. Really wonderful.
Thanks.
Thank you all.